thanks everyone for coming to the live. Hell yeah, dude, this is going to be awesome. So, going to do the ventilating severe acidosis that I did from ResusX. And unfortunately, my picture is sort of like in the way of the ResusX graphic, but appreciate Haney for inviting me out. This was like a really great talk. So, essentially, going over acidosis, ventilating it, the fact that it's generally kind of a nightmare. The vent isn't the fix for the acidosis piece of it, and usually just like makes things a lot worse. So, it's just like mitigating the harm that the ventilator is going to do as you fix whatever the underlying pathology is. So the case that George used wasn't the same case, but it was like sort of similar. It was a male with past medical history of HFrEF, hypertension, hyperlipidemia, type 2 diabetes, tobacco use, presented to the ED with fatigue, nausea, vomiting, polyuria, polydipsia, shortness of breath. Initial labs consistent with DKA, pH 712, glucose 645, beta hydroxy 8.4, K 5.8, creatinine of 2. This is his chest x-ray sort of in the midst of everything. And, gets fluid resuscitated because that's what you're supposed to do for a DKA is fluid resuscitate them to some degree at least. And unfortunately developed hypoxemia afterwards and had respiratory distress and crackles and was still getting treated and then eventually got intubated, unfortunately. So now you're in a real pickle, right? You're in sort of the thing that is going to make the acidosis not worse, but definitely offset sort of what you're able to do to make the patient more comfortable. So this is something from Dante's Inferno, which I asked people at the conference if they knew what it was, and I guess no sort of scholars there. But this is the entrance to hell, unfortunately. And in the Inferno, very famously, Dante says, "Abandon all hope, ye who enter." So which, is sort of the same with this, right? Like none of this is going to really be great. And it's not really the treatment that you need. Like the ventilator is going to make things worse. But how do we mitigate the harms is a question. So how do we mitigate the harm of the vent when you have a person who has, a tremendous minute ventilation? So 14, right? That's like pretty high. And if you put them on a mode like PRVC, which we know is the worst mode and it sucks and it's, whatever, it's the worst mode because as the patient sort of wants more support, they're not going to get more support, which is going to just be this sort of self-fulfilling prophecy of patient breathes faster, vent thinks that it needs to do less and less work as the patient does more and more work. So how do we sort of like negotiate these things? So we get back to the goals of ventilation, which I sort of updated. I don't know if anyone sort of like pays that much attention, but after talking with Melody about her goals, I sort of reevaluated them to some degree. So in descending order of importance. So the most important thing is safe pressures, right? We can't be ventilating patients with high airway pressures with plats of above 28, 30. We can't be ventilating them with high driving pressures. We can't be ventilating with auto PEEP. If you're ventilating the patient with these things, you need to mitigate them immediately. I don't know what that means in your specific situation. Is that lower volume? Is it less rate? Is it treating the auto PEEP? Is it doing something about the compliance? I don't know what that is. So I can't sort of make a blanket statement about how to make the pressure better, but you need to make the pressure better. So even if your gas is beautiful, if your pressures are unsafe, if you have auto PEEP, if your plateau pressure is high, if your driving pressure is high, that is the primary concern is ventilating with safe pressures, because regardless of the total volume, the thing that correlates with mortality and things getting worse, ventilator associated injury, is high pressures. So you need to mitigate the high pressures. So what does that look like? Depends on the situation you're in. Okay. So safe volume. What is the safe volume? We've talked about this maybe a couple times in the past 2-3 weeks with like ICU Boy, and Melody had a post recently about sort of what's a safe volume. Ventilator associated lung injury can happen outside of the patient having ARDS. So if you ventilate someone with 15 ml per kg, you're going to produce eventually lung injury. Now, besides that, I mean, what do we really know? There's not much that we know. We don't really know what the magic number of ml per kg is. We don't know if it's 6, 7, 8, 9, 10. We know that going lower, so 10, 9, 8, 7, 6, 5, 4, the patient can get more desynchronous because you're limiting the volume. So they feel like they can't breathe. So they're going to breathe faster. They're going to breathe harder. It's going to be uncomfortable, etc. So should we do that? I don't know. I don't think so. We shouldn't. We should try to sort of alleviate discomfort, right? That would probably be a good goal to shoot for. In patients who have a high minute ventilation need, i.e., they need some number, 14 liters a minute, 15, 20, who knows, right? They need a lot of bulk CO2 clearance per minute. If you restrict the volume, then they're going to have to increase the rate. When you increase the rate, what does that mean? That means that they're going to get auto PEEP eventually. And that's sort of, that is against one of our goals. So that's something to keep in the back of your mind. We don't know what a safe volume is. Is it 7? Is it 8? Is it 9? Is it 10? All we know that is an ARDS 12 is probably bad, 6 is probably better. And what that translates now is this sort of pressures situation. Driving pressure of, less than 15 in all circumstances is probably better than a driving pressure over 15 in all circumstances. Definitely better than definitely better in ARDS be less than 15, right? So safe pressure, safe volume, don't know what that volume is. That's really contingent on the pressure. Because if you have someone with emphysema, you can give them a pretty high volume and their pressure is not going to go high. So all these things are kind of fluid. You need to take them within context. The last thing that is important is the safe gas. So there's a great article called I think it's just permissive hypercapnia. I can link it in this. That goes through all of like the benefits of permissive hypercapnia, right? So you have increased cardiac output with hypercapnia. So remember, acidosis unloads more oxygen at the tissues, just sort of like by definition, by the dissociation curve. So some degree of acidosis might even be protective. Now, when you get excessive with it, pH 7.2, that's where I sort of put it. ARDS put it, ARDSNet put it there as well. PCO2 less than 80, PCO2 of 80 or more, somewhere thereabouts. That's where ARDSNet put it. That certainly becomes problematic. So while we want to be cognizant of the gas should not drive our settings. If the patient is paralyzed, then sure, we need to be cognizant of the rate, cognizant of the gas. If the patient's done being paralyzed, so you give them rock to intubate, they're not paralyzed anymore. My practice, and I think a good practice, is to drop the rate below what the patient's neural eye time is. So if the patient's neural eye time is 15, you shouldn't make the rate 16, right? Because then the ventilator just triggers and you're controlling the acid base of the patient. The hardest thing to do is control the acid base of the patient, especially if they're sick. It's just not possible. You're going to be working against the kidney, the lung. So it's better to just let them sort of like control their own acid base. Sometimes I hear things like, well, the CO2 is high or something. Remember, if your CO2, you have a tremendous drive to breathe from CO2. So if the patient's not brain dead and they're breathing, the CO2 being whatever it is probably what the patient's sort of brain, in air quotes, wants. So if it's 55, but they're comfortable breathing 18 times a minute, they don't look like they're in distress, then it's 55, right? We don't need to sort of chase this normal gas. We get into a lot of trouble chasing normal gases because then eventually down the line, it's time for the patient to wake up and breathe on their own and get extubated. But if you've been controlling the PCO2 and the pH so closely over the past week, 6 days, whatever it is, then you might need to wait for the patient to sort of like start to control their own respiratory rate. So I think a good practice overall. So then what happens is you put them on SBT, they're apneic, then RT says they failed for apnea, and then they're put back on a rate for another day. So no one should fail an SBT for apnea and there not be a reason attached to it. Meaning the patient failed for apnea, but they were still sedated. We're going to shut the sedation off and come back. The patient failed for apnea. They weren't sedated. The gas was a little acidotic, and they still didn't breathe and they're not brain dead. So then the question is like, do they have neuromuscular weakness? So when there's apnea on the SBT, that needs to be investigated. The number one step is, are they on sedation? Have they gotten medications that'll sort of suppress their drive to breathe? If that answer is no, then in sort of descending order, it's why are they not breathing? Is it meds? No. Is it neuromuscular weakness? No. Or even before neuromuscular weakness, is it meds? No. Is it the ventilator settings? Maybe the trigger's too high or something? No. Is it the gas? Are we overbreathing them? Is the pH 7.55 and they're going to not breathe for 30 seconds as their PCO2 rises and then triggers them, stimulates them to breathe? So you should never just leave apnea as a reason for SBT failing as the number one reason. That needs to be attached to some cause of the apnea. In reality, all these things should be sort of attached to something, but I don't think we do that maybe as much as we should. The patient's tachypnic, they had high worker breathing, whatever it was. And then we just sort of like, oh, they're tachypnic, no worries. Like, we'll try again tomorrow and then we'll see what happens. But what we should really be doing is like figuring out why they're not breathing, why they're tachypnic, why they're failing their SBT, and then going from there. So that was like a little bit of a rant, and I apologize for that. But so safe gas is last. So when we're ventilating patients, we want safe pressures, safe volumes. Don't know what that is. Lastly, a safe gas. So that's going to be sort of the least of our worries is a safe gas. Obviously, we don't. These things are more important in some situations. One of those situations is right heart dysfunction. One of those situations is neurologic injury. So if a patient has like acute neuro injury, then obviously that's something we need to think about. But as you know, the PCO2 being 55 and we made the rate 40 to like bring it down, that's not what we should be doing. And this is even more prevalent in ventilating acidosis because we're not going to be controlling the gas by any stretch of the imagination. So that's sort of like way out the window. So then the next question becomes, how do we sort of provide safe pressures and safe volumes? How can we do that to ventilate effectively and ensure that the patient doesn't have any ventilator associated injury? So remember, we're playing with two knobs on this thing, right? We're playing with either the FiO2 or the rate and the volume. So FiO2 and PEEP, excuse me, or the rate and the volume. The two things we're doing is affecting the oxygenation and the ventilation. So we can only do so much with the ventilator, but ultimately we're going to play with the total volume. We're going to play with the rate. We're going to play with the FiO2, the PEEP, and then that's how we're going to meet our goals of oxygenation and ventilation. So we only can sort of do so much with the vent. We can only have so many things that we change, and we need to make sure that we're safe when we set our settings. So let's see here. Okay. So what is acidosis? What is this metabolic acidosis? I keep talking about that. So remember, metabolic acidosis is the reduction in bicarbonate. I sort of leaned into gapped acidoses because the example was DKA, but obviously you can have non-gapped acidosis. So by whatever mnemonic you remember that by, I think it's like gold mark, mud piles, hard up, that kind of stuff. However mnemonic you remember it. But with DKA, we have an excess of keto acids because the tissues can't uptake glucose to use for energy, so they switch to ketosis, which generates some keto acids. The bicarb sort of eats that up to offset them to maintain electrical neutrality. You have a lower bicarb, lower pH, and then that sort of begets all these issues. Plus all the sugar in the blood because the tissues can't uptake it. So you're sort of having osmotic diuresis as well. So the question becomes like, can we just, give more bicarb? I mean, why do we have to be so nervous about like what we're doing essentially with the vent and like with the meds, et cetera? We know that just like adding more bicarbonate in doesn't exactly like fix anything specifically because these, if we're producing hydrogen ions, we're constantly adding in protons we need to get rid of. So even if we add in a little bit of bicarbonate, we're still producing this like, massive amount of protons through the ketosis. Number one. Number two is, if anyone's like taking care of a DKA patient, gotten the numbers, you can calculate the acid base status, right? Like you can calculate the base deficit. So how much bicarbonate sort of numerically are we missing? And when you're missing like 300 milliequivalents of bicarbonate, you can't sort of give that all in one shot, right? Because if you were missing 300 milliequivalents of bicarbonate, let's say, each amp of bicarb is 50 milliequivalents. So you need 6 amps of bicarb. So no one's going to sit there and push 6 amps of bicarb because number one, that'd be a huge, like a ginormous sodium load. And number two, it would also be sort of the CO2 load because in the amp of bicarbonate, there's a little bit of dissolved or undissolved CO2 sort of existing in between, sort of coming out of solution, going back into solution. So focusing on the bicarbonate doesn't really get us out of the hot water. What we have to focus on is, before, which is the protons. So getting rid of the protons, so providing insulin, et cetera. And then getting rid of the waste product, which is CO2. So how do we get rid of CO2 when you have a patient that's not even young? I mean, like most of our patients with DKA, they can tolerate sort of a high worker breathing. I brought this up at ResusX, which was there was a nice paper in Annals of Thoracic Medicine. I forget. I can link that too. But I did a post on it last year. Essentially, if there's no resistance or compliance issues with the lungs, so there's no resistance issues, you don't have asthma, you don't have COPD, and there's no compliance issues, let's say there's no pulmonary edema, pneumonia, et cetera, you can do about half of your maximum voluntary minute ventilation. So if you sort of rebreathe CO2 and you just, pant it as much as you could in a minute, that comes out to be like 30-ish by your total volume, So, if you did something like 600 total volume, 30, 35 times a minute, I mean, that's a pretty good minute ventilation. That's like, that would be, if you had 600 ml, so 600 times 30 would be 24 liters a minute, right? So that's pretty good. So what you're saying is you could do half of that. So 12 to 13, let's say, you could do that sort of indefinitely, right? That's what the paper postulated, was that half of your maximum minute ventilation, whatever that is, in 1 minute, you could keep up with that as long as there's no compliance or resistance issues. You can keep up with that almost indefinitely. So it shouldn't surprise you with a kid who comes in, maybe who's got DKA, they're 20, they run out of their insulin, whatever it is, and they're breathing, 30 times a minute, and they have this tremendous drive to breathe. They can keep that up for quite a while. And it's only until sort of the very, very end, when they really start to sort of run out of juice, that you need to think about intubating them. But that's the point, is to sort of get ahead of that, treat the before problem, which is the hydrogen ion production, and then prevent that from happening. What doesn't treat metabolic acidosis? Unfortunately, bicarbonate doesn't. This is bicarb for everyone that's wondering. Bicarb, the ventilator doesn't, and fluids definitely don't, right? So just doing these things in of themselves for metabolic acidosis isn't going to treat the metabolic acidosis. You have to figure out what the metabolic acidosis is. If it's not DKA, then you need to sort of go through your differentials. Is there some lactic generating something going on? Did they drink a toxic alcohol, perhaps? I know we don't ask that question a lot, but that is a cause of metabolic acidosis that we often don't think of. So you need to sort of have that in the back of your mind. But all these things don't sort of treat metabolic acidosis. So if we intubate the patient, the thing that I want to highlight is, like, how does the vent know that we want a breath? So remember, if this dude is sort of, has eyes closed but not sedated, because we shouldn't sedate patients just for the hell of it, we should keep them awake and alert. But if he was just sort of had his eyes closed and he wants to let the ventilator know that he wants a breath. I mean, how does it know that? There's not like a Neuralink from Elon Musk in the patient's brain. The vent has to sort of figure out, like, hey, man, this guy wants a breath. Like, I'm going to do something about that. So the patient starts to interact with the ventilator, drops his or her diaphragm. There's flow or pressure is taken from the vent. The vent senses that. The vent is like, this guy wants a breath. Let me pressurize my circuit, et cetera, and then, start flow. So that all takes a certain amount of time, right? It's not instantaneous. It takes some time. And I had this of Crunch from, Professor Crunchio, OK Med podcast. I think it's the number 3,500 podcast or something in America. It's very impressive. So Crunch has on, a high altitude trainer. It doesn't do anything for his breathing besides make it harder to breathe. So he's got to, suck in much harder to breathe when he's got the high altitude trainer on. Same thing with the ET tube. The ET tube just makes it harder to breathe if you're going to do it spontaneously. Now, you need it, et cetera, but the ET tube, whatever size you put in, is going to be less than the diameter of the trachea itself, or wouldn't fit. So by definition, the resistance is going to go up. But my point is, the vent is always sort of like a half second behind. So, 350 milliseconds. So just like a half heartbeat behind the patient's breathing demand. So if you have someone with metabolic acidosis, you're already setting them up to fail, because the vent isn't going to be able to sort of keep up every single breath with what the patient wants. It's always going to be just a little bit behind. And that's important, I think, to keep in mind. Now, we harp on this a lot, but at the end of the day, if the patient with DK needs to be intubated for airway protection, let's say, because they're really gorked, or they're not responding, or whatever it is, or you can tell they're running out of gas, they're about to, they're going to tire out, etc. Then you need to intubate them, and then it is what it is. You intubate them. It's not like the end of the world. You can manage it. Just need to set it up. You need to know what to look for, and then set up what you can to mitigate the negative side effects. The other thing to remember is that the diaphragm requires a certain amount of cardiac output from the heart to function, right? Now, it doesn't require much normally at rest, because if it did, then that would be sort of counterproductive to us being, like, evolutionarily, right? Because if we needed a lot of our cardiac output just to sit here sort of and rest, then that's not exactly like a great evolutionary advantage for us. But when you are under tremendous duress and you have a high minute ventilation need from acidosis, from fever, from sepsis, from exercise, a lot of your cardiac output gets diverted to the diaphragm so it can move that acid load, that CO2 that you're generating from your muscles, from respiration, et cetera. So What I'm saying is that if you have someone with DKA and they have a lot of like acid generation from their disease process, then, the good thing is that you've sort of taken all that cardiac output that might have gone through the diaphragm to sort of move that CO2, move that gas. And, the vent is sort of doing some of that work. So you don't need as much cardiac output sort of diverted to the diaphragm, and you can divert that cardiac output to other tissue beds. So it's while it's not ideal, it's not sort of the worst thing that could happen intubating a patient with severe acidosis. So then the question becomes like, how can you tell that the patient needs sort of more help with the ventilator? So this is pressure support, and there's a lot of like sort of ringing in the circuit, and I don't know where I got this waveform from, to be honest with you, but the things that you guys should take away is that this is pressure support, so this is essentially pressure mode, right? So if the patient was not active, this would look like natural decay, like it would sort of peak here and then come down to some baseline, right? But this is sort of staying above, like this is almost looks like a square waveform because the patient's just pulling flow out of the circuit the whole time. And then he sort of breathes out, and then you can tell from here there's sort of this upstroke in the pressure. The patient wants to breathe out, so we have a flow or support dysynchrony. You have a cycling dysynchrony. You have a triggering dysynchrony because the patient starts to sort of pull down here. He's got to pull down super hard to sort of get the ventilator to trigger. So he's probably working to get some auto peep. We can tell there's auto peep because the flow doesn't get back to the baseline. There's actually no discordance in the. Looks like there's no discordance in the inspiratory and expiratory curves. But what this patient's doing on the vent is essentially just panting, right? They're on the ventilator. That's what they're doing. So, I mean, how do you mitigate this is the question. How you mitigate it is increasing the pressure support, right? So the patient wants a certain amount of volume from the vent. And in order to move said volume through the tube into their lungs, just as a numbers game, there's a certain delta that needs to be set up to sort of move the chest wall, move the lungs. So if that delta is, let's say, 15, just for argument's sake, and you're only supplying 5, then that other 10's got to come from somewhere else. So if the other 10's got to come from the patient, because if they don't pull down with 10 centimeters of water, they're not going to get this volume. If they don't get this volume, they're not going to be able to satisfy their mid ventilation need. So, an important thing to recognize is that when you see a waveform where it's like discordant with what you would think it would be, like what is normal, the thing you should be thinking of is, does this patient need more support? Are they under supported is a question. And this guy's under supported. So same thing, similar at least. Pressure control, right? There's certainly a delayed cycle because there's a huge sort of pressure jump at the end. Also sort of panting on the ventilator, probably auto peep, etc. But what what can we do, right? Like, look, we've given him 15 centimeters of water pressure. He got 1200 ml, right? Which is a tremendous amount of like total volume. And he's breathing 22 times a minute. So his minute ventilation's 30, which, I mean, if you were not intubated, that'd be hard to do. So, what can you really do here besides understand that there's going to be a limit to what we can do? So it depends on the gas, right? So if you had this and the gas was 727 or something, or like sort of teetering, I wouldn't say, well, just paralyze him and then we'll figure it out, because you're going to be bound by the time constant with how fast you can sort of breathe the patient. So it's not like you can say, we'll paralyze him, we'll make the total volume 500, we'll just put him at a rate of 30, right? And try to get close to, first of all, because even if you made the volume 500 and made the rate 30, that would make the med ventilation 15, which is basically half of what you're giving him now. So that's, that's sort of out the door. Now, obviously to some degree, auto PEEP is going to impinge your bulk ventilation success, because you're going to have less alveolar ventilation, so less gas reaching the alveolus, because if you have auto PEEP, which is essentially just volume stacked on itself, right? So we put in 500, we've only got out, we only got out 300, there's 200 left over. Then the next breath comes, and now it's like another 500 stacked on top of the 200, but there's a certain amount of gas that doesn't sort of leave each breath cycle. So you get this increasing dead space. My point is that there's going to be some vent screens that you're going to just be able to do what you can with, do the best you can. And like we said, the ventilator isn't the fix, right? If this guy was dying from DKA or from HHNK or had renal failure, like the fix is fixing the underlying problem. There might not be anything we're going to be able to do with the ventilator to offset what's happening here. And that's just sort of, that's the way it is. So volume control, what you need to recognize is that, why is the pressure curve dipping down? And there's -3 here. So when it hits this line, that means that it's reached -3, meaning the patient's sucked down so hard, they've sucked all the flow and pressure like out of the vent circuit itself that it's depressurized down to -3, which is just a tremendous amount of effort happening with the patient. So, and what they, and classically you would call this sort of a flow dysynchrony. So how can you fix it? You can decrease the eye time, which would ultimately increase the flow. I think this patient probably just wants more volume. Now, if you're not ready to give them a bigger volume, then that's a question you have to ask yourself. So if they had, if they're, and unfortunately I don't have the set volume here, maybe it's like 400 or something, let's say. Um, Maybe they want 500, right? Maybe you're not willing to give them 500. Maybe, they have ARDS or something, or whatever the reason is, and you don't want to give them a large volume. You can only sort of control so many legs of this. So if the patient's got a tremendous drive to breathe, wants a bigger volume, then there's not going to be much you could do about that. We can't sort of just sedate it out of them and get to that later. But, how do you sort of like negotiate the patient's drive to breathe with the goals of ventilation, oxygenation, with like what the, making the patient comfortable, right? Because you could put them on a pressure support of 30, let's say, right, or something crazy, and get a huge volume, get, 2000 ml or whatever it is, and they'll breathe 4 times a minute. But like, is that really safe is a question. So for this patient, I think the less safe thing is the patient pulling down so hard that they're sort of like getting to the negative PEEP numbers, because they're just from like a diaphragmatic point of view, they're probably injuring their diaphragm at this point. But what can you really do? Unless you're ready to go up on the volume, you can come down on the inspiratory time a bit. That might help, but you're going to be kind of stuck if you don't want to sort of do anything about it specifically, i.e., increase the volume or make the flow higher. So this is, Hamilton APV. It's sort of like PRVC for Hamilton. We all know it sucks, etc. This is my favorite because whoever, as a general aside, if anyone ever puts up a pressure volume curve, definitely in a pressure controlled mode, which this is, they definitely don't know what they're doing. So you could just sort of take that to the bank. Because what you should see is sort of the vent pressurizing to some number, and then the volume, going up, and then depressurizing and the volume coming down. But you don't see that all here, right? So there's no pressure supplied from the ventilator. So what that means is that the patient's doing all the work. So for this volume that they're getting of like 500, the patient's sucking down so hard that the vent isn't supplying any pressure. And there's one thing that I didn't point out before that I want to point out now, which is this is, and I didn't point it out at ResusX, but just because I was sort of running out of time, but there's this little sort of tail here, right? So we call this the trigger work. So the patient's got to drop the pressure, pressure flow, whatever, in the circuit to get the vent to trigger. So this is called the trigger work. Now, every patient on the ventilator should be doing the trigger work because you want the diaphragm to be firing. You don't want the diaphragm to be getting atrophied. So if the patient's at least doing the trigger work, the diaphragm is active in some of the work of breathing. So you want the patient to do the trigger work. You don't want them to do a tremendous amount of trigger work, obviously, because then that sort of like goes to the other end of the equation, which is that you get diaphragmatic injury from the diaphragm sort of doing too much work, but you want the diaphragm to do some work. So you want the diaphragm to do the trigger work at least. And on the pressure volume loop, that little sort of dip down in the beginning, or sort of not in the beginning, but that dip down here, that is the trigger work. So the work of breathing that is attributed to triggering the ventilator. And you definitely want the patients to be doing that because that's sort of diaphragm protective. You don't want them to be doing this, which is like the trigger work and the rest of the work of breathing, because they're doing too much work. So what are some signs of increased work of breathing on the ventilator? So some signs are, so it depends on the mode. So if you are in volume control, pressure control. So in volume control, remember, we're controlling the flow volume. We're not controlling the pressure. So the pressure waveform should sort of look like something, right? It should look like normal in air quotes. And what I have in the pink sort of purplish is normal. It should sort of look like this. Some people describe it as a tombstone, which drives me nuts, but it should sort of look like tombstone-y, like a square, like this, where it's supplying pressure throughout. So what I have here sort of drawn over it is that, everywhere that there's a gap between the purple and the yellow line, that's all pressure that should be there that isn't there. So the question is, if it's pressure that should be there because the vent's supplying it, but it's not there, who's supplying the pressure? The patient supplying the pressure. So you can tell that they're struggling on these settings too, because it should look like this, and it doesn't, number one. Number two is that, in expiration, it should sort of be this like passive, natural decay looking thing. What you have here is, almost a straight line. And what you have here is it there not being a sort of, a natural decay of flow, which is what the purple is. What you have is probably a early cycle, which is why sort of the flow curve is like pulled up around here. And then the patient's just like breathing out. So like breathing against the circuit until, so, breathe, like taking a breath in, blowing out hard. So, and then taking a breath in, blowing out hard, taking a breath in. So that's what they're doing on the vent. So whatever the settings are here, so 15, 530, 5, this isn't enough help from the vent. Same thing with pressure control. And this, this gets down to like knowing what normal and abnormal is, which has been sort of like a central tenet, but I digress. So I put this up because it's like a nice dichotomy between what a passive-ish sort of thing is and a not passive sort of curve is. So, this is passive. They get less volume here because this is shorter than this. In this breath, they sort of like interact with the circuit and pull the flow out. So they get a bigger volume, but then sort of blow it out. So, here the patient was pretty, and I took this and I remember specifically the patient was pretty tachypnic because they needed a minute ventilation of 20, but they didn't have like enough sort of umph to suck down really hard and get more flow out of it, except intermittently. So, they're breathing quickly, but they're not breathing like really forcefully to get more volume. When I increase the pressure support for the same amount of effort, they got a bigger volume. So ultimately, what that did was slow the rate down. Now, how much bigger of a volume? They got, like 700-800 cc's. Is that a lot of volume? It's a lot of volume, right? That's creeping towards 9-10 ml per kg. But remember, right now, the issue is that there's probably a bunch of auto PEEP that's like building up, which is probably interacting with, number one, the patient being able to trigger, and number two, the gas exchange. So, in our hierarchy, that's more important to take care of rather than like either the volume being perfect or the gas being perfect. See here. All right. So the ultimate question is, would you limit the pressure control? Would you limit the support that the vent's giving in order to control the volume? I don't have a good answer to that. I think if it's excessive, whatever you consider excessive to be, I personally start to think about these things when we get above like 10 ml per kg, only because it's like ubiquitously known that, 10, 11, 12 ml per kg is a lot of volume. Even if the pressures are okay, it starts to make me a little squeamish. And I start to think like, what can I do? Now, if this patient's pulling 1200 on pressure control, what can you do? Like, what can you can try to sedate them, et cetera. That doesn't work very well because when you have a tremendous drive to breathe for whatever the reason is, whether it's from acidosis or whatever, it's hard to sedate it out of the patients. And I'll show the example that I showed before. Do you decrease the pressure control, like the inspiratory pressure support to lower the volume? The patient could also breathe harder to get that volume again. So that's, it doesn't always work. Or do you limit the eye time? Because the eye time, if you're constantly breathing throughout the inspiratory cycle, if you had an eye time of 1 second versus 0.5 seconds, the eye time of 1 second would have a bigger volume. Now you can get into cycling issues. So if you make the eye time too short, it can start to cause delayed cycle or premature cycle, can start to cause premature cycle, which is another dysynchrony and you have to sort of deal with. But the one way to limit the volume would be to shorten the eye time. And remember, this patient was like sedated to death. They're like RAS minus 4 or 5. Sedation depth and RAS score for patients that are intubated for whatever reason, if they're critically ill with sepsis, some acidosis, we saw this with COVID for like 4 years, right? They were on multiple drips, ketamine, fentanyl, probe, dex, Versed, et cetera. And they're still double triggering. They're still, and probably a lot of that was reverse triggering, but that's a whole separate issue. But we've all seen patients that are like very sedated that are still breathing very heavily because from this study, which was a nice study that was shared by Matt Schuba, aka the intensivist, like a while ago, the patients with the highest RAS, so like -4, -5, were some of the patients that had the highest occlusion pressure. So for those who don't know, occlusion pressure, at least on the servo, is the vent sort of obstructs flow just for a brief second to see like the angle of depth of how much decrease in pressure there is. And this gives us some insight into the neural drive to breathe. Now, if you have a high neural drive to breathe, you don't know why. Is it because they're acidotic? Do they have pain? Whatever. But nevertheless, the patients in this study who had, I think, ARDS, most of them, and pneumonia, who had the highest neural drives to breathe, often had the deepest RASes. So they were probably trying to sedate, the drive out of them, but you can't because it's just tremendous. So I don't want to sort of like go through all this and not have any like practical advice. So what I do personally is that, so this was from the taxonomy paper from Matt Schuba again and Eduardo and Chapper and their work, Cleveland Clinic. So this is a beautiful graphic, right? So as demand goes up from the patient, and this is P vent or sort of pressure delivered from the vent, you think of it as support. So like support from the ventilator. So when you have things like PRVC, volume control, volume support is essentially sort of like AVAPs for the vent if you're intubated. So it's sort of like you can target a volume with the pressures. It's kind of like PRVC, but like a little bit different because it's a spontaneous mode. So the patient has to be breathing spontaneously. PRVC you can set a rate, etc. But I digress. Nevertheless, as the demand goes up in all these vents, the support goes down. Now, NAVA, so PAV was on the Puritan Bennett, don't have that anymore. NAVA is on servos. So NAVA is like neurally adjusted ventilatory assist. So how hard, how forceful your diaphragm's contracting, the vent senses that, and then it's like, oh, this guy must need more support. Then it increases the pressure support. I currently don't use NAVA. Some people do. Not a lot of people do, though, honestly. But what I do is I usually just put them on something where I know they're going to get a set amount of pressure. That way, if I think they're getting too much pressure, so they're getting 1500 ml of total volume, I could back off on the pressure if I want to. I don't want to put them on PRVC where I just pick a random number of total volume, pray that it's going to be enough, and then they get tachypnic, and then the vent starts supplying less and less pressure because as the demand goes up from the patient, the support from the vent goes down. And ultimately, that's going to lead to torture, and we try to prevent torture with the vent, at least from my perspective. So this gets back to a question I posed on the gram, which was, what would you rather? Would you rather A is a patient who I inherited, I think, on service. They were at like 6 or 7 cc's per kg, very tachypnic, very agitated in air quotes, requiring multiple drips, pushes, Versed, etc. So I just switched them to pressure control. Took bigger breaths, got 650, but slowed down, looked more comfortable, and they had emphysema. So I knew that they could handle like higher volume because their compliance is so good that we're not going to have all these barotrauma issues. So getting back to our goals, even though the volume was much higher than I would normally go for, it wasn't causing issues with pressure because the compliance was so good. Okay. So, I was good with this and I left it at B. And I was asked multiple times, like the total volume is high, you worried about that, et cetera. And I got back to the point where when we limited the volume in a spontaneously breathing patient, they just get more tachypnic. As you get more tachypnic, you get more auto peep. As you get more auto peep, you get more like breathless, feel like you can't breathe, which then makes you anxious, then makes you breathe more, then you get more auto peep, and then it's this vicious cycle, spiral. So for me, I'd much rather a higher volume with a lower rate than a lower volume and a higher rate. So when I approach someone with metabolic acidosis that I'm going to have to intubate or is intubated and they have a tremendous drive to breathe, I let them, when they're paralyzed, you need to think about the rate and the volume, right? Because they had some rate and volume before they were intubated, and now they're intubated, and we're responsible for their acid base. So that's one thing, which is fine. But when they're not paralyzed, what I find at least, the easiest thing to do is just like get out of their way. So, give them some amount of pressure support. Now, whether that's on full pressure support, so like pressure support mode, or on pressure control, give them some delta. So, I usually start with like a PEEP of 5 and a delta of like 10 or 15. If I notice that they're like really breathing hard, I won't go as much as 15. I'll do something like 10. And I just sort of titrate from there. And if they're still getting too much volume, and I can't come down on the volume of the pressure anymore, then I'll decrease the inspiratory time because I know that'll decrease some total volume. Now, I don't make it so low that they're going to have cycling issues. Sometimes they do. But remember, back to the first slide, this is not the solve for the problem, right? The ventilator does not solve the metabolic acidosis problem. The ventilator buys you time to solve the metabolic acidosis problem as you try sort of not to kill them with the ventilator or torture them, ideally. So I think this is the last slide. And unfortunately, yes, the last slide. And unfortunately, I don't know why the chat doesn't work. That's really unfortunate. Sorry about that. So obviously any questions you can like email, Instagram, etc. And I don't know if this is like if it's me. It's not my first time doing a live, so I don't know why it's not working. It's really weird. Anyway, that's unfortunate. Okay. All my friends in the YouTube world, appreciate your time. And hopefully this was helpful. I'll be putting it on YouTube probably like tomorrow, the next day. It'll be on the channel, probably like release it as a podcast too and stuff. So there'll be, more opportunities to like to watch it and go over it, and you can ask questions, etc. So appreciate your time. Thanks everyone. Hope you have a good night.